Global pandemic coronavirus continue to have a serious impact on people, especially for two sides, physiological and psychological.
My area in Kibera is overpopulated, such that when a person has COVID-19, self-quarantine is very difficult. On a typical day, I can reach 200, in a week, 600 to 700 people.
In Freetown, we registered the first case of coronavirus the 31st of March. The main effect, the main impact that the pandemic has been in the health system, I would say, has been the fear more than the coronavirus. Immediately after, in April and May, we registered a big decrease of access to the healthcare posts, especially for the pediatric and obstetric cases. The second impact has been the closure of some hospitals due to positive cases between the health workers.
Is to identify the sick people, refer them, and do the follow-up. The other thing is to teach them on basic hygiene, how to hand wash, keep social distance.
AHMED being a key stakeholder in the country, we also bought into this national response. So we partnered with the Ministry of Health to translate IC materials, general information on what the signs and symptoms are, what the prevention measures are, and what they should do in case they suspect of being infected with the virus.
Has been to create immediately a separated fleet of ambulances to refer cases of coronavirus suspected or confirmed. We also support the Ministry of Health with the referral of sample to the labs to conduct the test.
أما المرضى المزمنة لاحظنا التزامهم بشروط الصحية كارتداد الكمامات والكفوف وغسل اليدين والتباعد الاجتماعي وأخذ العلاج بصورة منتظمة، وقمنا بتوعيتهم بكيفية أخذ علاجهم والتباعد الاجتماعي.
When COVID-19 exploded also in the country, one of the priority of the Ministry of Health and of OUMA was to ensure that chronic patients were retained into treatment. This was made by identifying best practices with the engagement of community health workers and community health activists.
From our side, as Intersus team, we are work hard to provide support for them, explain the prevention method by awareness session. Also, we are provided medication to PHC for them.
The challenges that I face during this COVID-19, we don't have the PPE. Then the other challenge due to infrastructure.
So it's important that everyone is kept up to date with the information so that no one is left behind.
Santiago.
Che si tentano, e nella seconda metà avremo degli importanti interlocutori istituzionali italiani.
In the second part, we will have some very important Italian speaker, the director of the Agency for Cooperation and Development, director of General Director for Development Cooperation and the Italian Agency for Development Cooperation, and also Sandra Zampa, the Secretary of State for Health. So we will hear some in detail studies about what we heard in the first part. So we will have a very important institutional representation by 𝐻MED OUMA, Deputy Director of Africa CDC, Centers for Disease Control and Prevention. The body coming from the African Union dealing with the control and the prevention on the overall continent. This is the better source to have a general overview of the situation. The impact of COVID-19, it is not only a direct impact, that is to say, a pandemic, but also the effect it has on fragile health systems. So the programs we are forced to disrupt, the fact of disrupting different services because many can't reach hospitals or emergency rooms even if they have chronic diseases. So all a series of problems created by the pandemic. I also think of the problem of early pregnancy. That is an act that is again severe and worsened by the closure of schools, and young people are no longer dealing with education in schools. The origin of the pandemic in Africa, the first COVID case was in Egypt in February 2020, if I'm not wrong. 1 week later, that in the Democratic Congo Republic, a patient was discharged for Ebola pandemic. So these few days spent between the end of an emergency and the emergence of a new emergency gives us an overview of the fatigue and the fragility of these systems that are continuously affected and has to deal with huge problems in the health sector. Before giving the floor to the on-field experiences, I'm glad to give the floor to President of the Link Association, Roberto Ridolfi, that, as I know, he is a new president. He has just been appointed. So greetings to Roberto. We're glad to hear you. Please, you have the floor. Thank you, Mr. Veronesi. Good morning, everybody, and welcome to this webinar. This is my first public occasion as president of the Link Association. I'm moved. I want to thank and say hi to all the representatives of Italian institutions, of the Ministry of Foreign Affairs, International Cooperation, of the Ministry of Health, and of the 𝐼𝐸𝐾, Italian Agency for Development Cooperation.
CDC for their participation. Thank you. Buongiorno a tutti. Il tema vero e proprio lo dice il titolo, non bisogna lasciare nessuno indietro.
As the title says, we don't have to left anyone behind. In this crisis following the pandemic, this is something that is more difficult in comparison to 3 years ago. The cooperation don't have to decrease, but is expected to decrease, and the pandemic in the different countries creates stress for budget and organization. So the objective of our webinar is bringing the experience of the civil society organization in the countries we operate. In this 2-hour seminar, we want to concentrate on Africa and Middle East and on the effect that COVID-19 brings with it. Africa CDC, so Africa Centers for Disease Control and Prevention, will tell us about the strategy to counter the pandemic, but also what kind of partnership we need. We see in Europe the very recent debate on vaccination, who is having the vaccine first, why, how priorities are decided, and why. This is something that in Africa will be done which are the responses apart from treatments and vaccines with the help of civil society organizations. With our associate, Link Association, we want to answer questions. Who are the victims of the pandemic? Which inequalities arise? We read that the first 1,000 men in the world got rich because they doubled their wealthy. And we know that 700 million poverties reached the soil we already seen before. So these numbers were exacerbated by COVID-19. I particularly dealt with disruption of food supply chains, and we've tried to find some food system in order that they are shorter. But maybe we should ask some questions on globalization, not only in the health sector, but also in other sectors. This is occasion to which Italian institutions that I thank again, many friends that I meet again after the positions I had in the past, I urge them to know how the Italian institutions want to encourage support systems to the most vulnerable countries. Yesterday, we closed the launch of G20, the big platform for civil society, G20 and the Italian presidency. I just want to say something. Italy has a unique opportunity this year that we will have again in 20 years to put in the agenda and the objectives of G20 summit all issues linked to what I will define recovery plan for poor countries, in particular for the continent that is most associated with European. Link made a proposal, released G20, in order to restructure the debt to find some places for sustainable development. So I wish you a great job. I'm here with other networks and law office to sign an important agreement to have a more coordinated approach towards Europe as civil society. And I would like to give the floor to Pietro Veronesi again, the moderator. I thank you all, and I ask you to think, to reflect on how to attend practical conclusions and objectives. Thank you.
Mr. OUMA, could you switch on your camera, please? Thank you.
We know that you are several people connected to who have joined this streaming. We don't really know you. We think that many of you are part of the works, but we think there are some people interested in the issue that we're going to try and develop more in these 2 hours. You have the possibility of asking some questions because we will have a session to transfer your questions to the speakers so that you can have answers to your questions. You can use the chat. I will now give the floor to Ahmed Ogweluma. As I said before, he is Deputy Director of Africa Center for Disease Control and Prevention. He's going to give us a general overview of the pandemic on the overall continent. Please, Ahmed Ogweluma, you have the floor.
Thank you very much, Santiago, and good afternoon, good morning, good evening, wherever you are. It's really a pleasure to be here this afternoon from Addis Ababa to share a few things about Africa CDC and what we have been doing in as far as this pandemic is concerned. Let me start first by the sad news, and that is that we have passed the 3.5 million mark on the African continent of those cumulative numbers of people infected by this virus. And we have also passed the 88,000 mark of those who have died as a result of COVID-19. Now, I would like to share today really areas that we have been working on in as far as getting the pandemic under control is concerned. We have been working in several areas, and I would like to really start by saying we have been successful in Africa because of very concerted leadership from our heads of state, particularly the Bureau of Heads of States of the African Union, who, under the chairmanship of President Ramaphosa, the president of South Africa, have been giving us very clear guidance on what we need to do as Africa, what we need to do as the Africa Union, what we need to do as Africa CDC to ensure that we are getting a good hold of this pandemic. Now, just in summary, some key things that we have done in as far as leadership in the response of to COVID-19 is concerned, we have done about 8 very key things. The first is when this pandemic started, when the first case was identified on the continent in Egypt in February last year, 2020. The first thing that the Africa Union did, Africa CDC, was to call all health ministers to Addis Ababa to discuss a joint strategy of tackling the pandemic. And this strategy enhanced cooperation, collaboration, coordination, and communication across the continent, across all the players that are involved in preparedness and response activities. And it provided a very clear roadmap of what we need to do as Africa to be able to respond to the pandemic. Under the strategy, we also created the Africa Task Force for Coronavirus. And this task force is made up of the directors of national public health institutes or those who are leading response activities at country level. And these are generally technical experts who meet every Tuesday afternoon to be able to share what is happening on the ground and redirect, if necessary, any response activities that we have on the continent. Of course, we invite colleagues from multilateral agencies like the UN agencies, NGOs, and other partners who are working on the continent on response to COVID-19. The third thing we did was to launch the Partnership to Accelerate COVID-19 Testing in Africa. We call it PACT. And under PACT, we mobilized partnerships, we mobilized experts, we mobilized community health workers, we mobilized supplies like test kits and the necessary accessories so that we could be able to increase testing, tracing, and treatment on the continent. And in fact, the PACT initiative remains a very key part of our response on the continent. The fourth thing we did was to tackle the issue of supplies. You will recall that when this started, the pandemic started, particularly in Africa, the supply chain was completely disrupted. And getting access to diagnostics and medical equipment and protective gear was very difficult. So what we did under the instructions of the Bureau of the Heads of States was to form the Africa Medical Supplies Platform. And this platform has made it easier for online, as an online marketplace for procurement of all the supplies for COVID-19 that we need, including vaccines now are on that platform. So countries can be able to go, choose what they need based on pre-negotiated pricing, and then those are delivered directly to country level after Africa CDC has negotiated with manufacturers and suppliers. The fifth thing we did was an initiative to accelerate COVID-19 vaccine trials on the continent. We formed a consortium for clinical trials. And this consortium has been working round the clock to ensure that we have good clinical trial sites. We have sites that can be able to be used for quality control, sites that can participate in the development of vaccine candidates. And we have a lot of trial sites right now that are being used by the various vaccine candidate manufacturers globally. The sixth thing we did was to launch the campaign to promote harmonized and standardized entry and exit requirements across all African member states. This, we call it the Africa Against COVID-19, Saving Lives, Economies, and Livelihoods. And this campaign has resulted in the Trusted Travel initiative, which now is being rolled out across the continent for our member states to have in place a system that ensures we as Africa can be able to trust any certificate that comes that is presented at the airport. And it is a network, it is a portal that networks laboratories that have been given authority by national governments. It is a network that ensures that each and every certificate that is issued for COVID travel is captured and can be able to be confirmed at the airport level during travel. The seventh thing we did was to address issues of access to vaccines. And vaccines have become very precious, and the numbers that are being produced are not enough for the demand. And we demand equitable distribution of vaccines across the world so that we are all getting vaccinated at the same time. That's the only way to be able to stop this virus from spreading. And so President Ramaphosa, the President of the African Union, established the African Vaccine Acquisition Task Team. And this team is the one that has already negotiated the 270 million doses that were announced last week. Out of that, we expect deliveries to start within February, particularly for healthcare workers with support from various sources of funding. The eighth thing that we have done is vaccine delivery. If you have vaccines and you don't deliver them to where they are required, then the vaccines cannot help. It is vaccination that saves lives. It is not just vaccines. And so we have put in place an elaborate system of understanding how prepared each and every one of the countries in Africa are, how ready are they to be able to vaccinate, so that as the vaccines become available, we quickly can be able to move from just having vaccines to having vaccination being done on the continent. We believe that most countries in Africa are going to be ready over the next 1 month or so, and they will be able to deliver vaccination to the majority of the population. Our target is 60% of the population. Now, let me shift a bit to address the issue of partnerships. We cannot be able to do all these on our own, and we need partners.
Okay, yeah, this is Vicente.
And as we do with partnership, we have several constituencies of partners. First is the African Union member states themselves, the countries in Africa. Very key, because implementation goes on at country level. And if the countries are well prepared, their institutions are well prepared, then we get success. As we have shown with our response to COVID-19, we have kept the numbers low, we have kept our actions very coordinated, and we have ensured that cooperation results in benefit to each and every country on the continent. Apart from the African Union member states, we have individual institutions within the countries, whether they are national public health institutes, whether they are research institutes, whether they are public health-based institutions, or policy organs, both at country level and within the continent. We are dealing with these African institutions so that they can be able to leverage on their advantages and their strengths to ensure that we are getting successful. And we have done this very well, and that is why you see the numbers are low. Third are bilateral and multilateral partners. These are either other countries or intergovernmental organizations or non-governmental organizations, whoever it is that can be able to form partnership with us to address the issues of COVID and particularly the broader health security issues on the continent. We are engaging with these types of partners. Of course, we also have philanthropies and foundations that have been very key in availing very quick resources to the Africa CDC so that we are able to tackle the issues of COVID-19 right from the beginning in February, building capacity and ensuring that countries had the supplies that they needed. And now we are expanding that beyond just philanthropies and foundations. We are going into the private sector. We are encouraging countries to have private public partnerships so that the private sector can also be able to contribute to the fight against COVID-19. Let me finish by saying that to be able to sustain all that we have done, we must look into the future. And into the future, we must be able to address a few things. Top amongst them is strengthening the health system. If we don't strengthen the health system, then the next pandemic is going to be probably worse. We need to strengthen the health system by ensuring the infrastructure is good, our health workers are enough, and they are well trained to be able to prepare for any other outbreak or any other pandemic. These are lessons that we are learning. Second is we must keep a good supply chain. Local production is extremely important. We can't have a situation where we're importing 99% of the vaccines we use in Africa, for example. We can't be able to have that. So we must ensure that our supply chain is maintained, local production is in place, and we are able to prepare for the next outbreak. Third is we must build our African institutions. Africa CDC is a good example. The Africa Medicines Agency is another example. The Africa Union needs to be strengthened to be able to address public health issues. We must have early warning systems, and we must have resource mobilization being done at country level. We should not wait for resources to come from outside. We are telling our governments in Africa, do resource mobilization, address issues of availability of emergency funding and emergency capacity. And finally is partnerships. We must go into partnerships that are going to help us to address issues more effectively. And this conversation today is part of that partnership conversation, and we hope that we can be able to expand our partnerships with our Italian friends. And in this way, we have an Africa that is more prepared for future outbreaks. I thank you for the opportunity.
Grazie molto a Ahmed Ouma.
Thank you, Ahmed Ouma, for the general overview you gave us. The 8 points you have listed give an idea of the seriousness that the challenge Africa is facing with COVID-19 pandemic. I think that it is the first time that Africa tries to face an ongoing emergency on the continental level. So this is the first trial, and when we could have a final assessment, this will be the benchmark on which all future initiatives will be assessed. Of course, the experience that you as a responsible of health system on continent level is a fundamental experience without previous examples. So you're leading a very challenging action. So I wish you all the best to you, CDC, facing this pandemic, and I hope that we can meet again when we could draw the conclusions. Now, to go more in detail and try to get closer to the individual realities, we're going to listen to some operators from the field. These operators represent the 4 NGOs. They operate in Africa, like, for instance,
Doctors with Africa QAM, also AMREF Health Africa, and in Middle East, InterSOS and IDOS. These are very important operators from the four NGOs. They have a very important background as for medical training, but also social medicine training and also public health. And they will tell us about what they're doing and the problems they are facing. First of all, I would like to give the floor to Joachim Osur, representative in AMREF. You have the floor, please.
Thank you very much, and much appreciated for giving us this opportunity to discuss some of our experiences with COVID in Africa. I'm trying to share my slides, but it tells me the host disabled the screen. I'm not sure whether it is possible to share. Control room. Are you able to make the slides visible for me? Okay. I can see them somewhere in the background, but I can't see them on the main screen. They are on. Okay. So I will have to use my own slides, and you can project the rest. Yeah, so some lessons from AMREF Health Africa on COVID-19. AMREF Health Africa is an international NGO, and we focus our work in Africa. And in a number of countries in Africa, the Africa CDC is one of our key partners, and some of the work that Dr. OUMA has presented, we are part of, and we appreciate the collaboration. But let me just also present, I will try as much as possible not to repeat what Dr. OUMA has said, and I will share specifically some of the lessons we are learning as an organization working in Africa. The first thing is that when it comes to COVID response in Africa, Africa is not one. The response is very varied based on which country you are talking about. I've given a few examples here: Tanzania, Rwanda, Madagascar. Very different approaches and very different outcomes. As you may know, up to now, Tanzania, you know, the government policies that they have ended Corona in Tanzania. And so for some time now, they are not collecting data, and they are not basically doing what the rest of the world is doing. While countries like Rwanda has gone far ahead of many countries, not just in Africa, but you know, in the world, to do things that are really innovative to manage the virus. And there are others like Madagascar also doing some of their things. So basically in Africa, the response is very varied, the experiences are very varied, and some of what Dr. OUMA presented is taken up well in some countries and not so strongly in other countries. So the outcomes of what we are seeing, basically, I can make some of the, you know, general outcomes of what we are seeing in the health sector. The resources are very stretched. A number of countries are basically reeling at the burden of disease. Because of COVID, we already had a weak system, and because of COVID, things have become really hard. And it's not just COVID management that is suffering. There are other health services that are not being attended to because of the stretch in resources. For example, human resources for health, the stretch is so that there is a lot of frustration among health workers, and we've had a number of health workers in countries going on strike, Nigeria, in Kenya, in Malawi, and basically downing their tools because they are overstretched and there are no supplies for their work. There has also been disruption in supply chain for most of the health products, including those for COVID. Countries that are landlocked, like Uganda, for example, depend on goods flowing across the continent. And sometimes when borders are closed, those supplies are disrupted, and you will find many days pass without goods reaching the country. There is reduced uptake of non-COVID health services, as I've said, because the services are not available as before, but also because of population issues, which I will talk about. The issue of transparency and accountability on use of resources by government is a real big challenge. I know it's not just in Africa, it's all over the world. And we've had monies getting lost, meant for health services and for COVID, and that's a big challenge. So a part of industrial action, COVID interventions are not always contextualized. I think African context is very different. A lot of people depend on selling things in markets, open air markets, where a lot of people come together and they buy and sell. We have nomadic communities who roam around trying to feed their animals and so on. So the context is very different. So when you talk of lockdown, for example, you cannot do lockdowns in Africa the same way you do them in Europe, because Europe you can have goods delivered in houses. You can have controlled supermarkets and so on. You don't have tribes that depend on their cows and have to walk around to feed those cows. So if you do a lockdown, how does a nomadic community, for example, then walk around feeding their cows? So contextualizing interventions is so important, but this has been a challenge because we've not taken time as Africa to think of innovative ways of managing the virus. And this has had consequences. So in the population, at population level, therefore, the disruptions that have happened in we trying to control the virus have led to lack of food. There has been hunger. And in some countries where we work, our staff have talked about COVID, and populations have said, we no longer want to hear about COVID. We are hungry, we need food. And that's a big challenge. There has been disruption in education, like everywhere else. But the thing in Africa is that this disruption has really affected the girl child. We've had high levels of pregnancy among children. We've had increasing levels of child marriage, and we've had practices like female genital mutilation going up because now community control systems for some of these vices has been disrupted. There is also a widening gap between the poor and the rich. There are people who depend on day-to-day working to get food or to take their children to school. So when the markets are disrupted, when things are not working as usual, then you have these people suddenly falling into poverty in a few days. And that we are seeing quite a lot. And even in seeking healthcare services, they are unable, there are parts of countries where there are no health services, and these people are unable to travel to seek for health services elsewhere. There is also falling trust in the health system as frustration about this pandemic goes on. We've seen people not acting like before with care, people not taking instructions to control the virus. And this, I think, is because of fatigue that has set in. We've seen stigma in communities, people basically stigmatizing those who are thought to be having or have had COVID. And this is a big challenge when it comes to controlling the disease. Now, what have we learned that works? One thing is that we need to shift power from the top to the bottom. I think Africa is unique, and controlling pandemic like COVID or Ebola really depends on how well communities are on the table in these discussions, how they feel involved, how they find their own solutions. So dialogue with communities and getting answers from them on what works is very important. And community health workers are so key in this process, because community health workers are like the gatekeepers. They work with households, they refer them, they advise them. And so ensuring that the community health worker is available and well-trained to work with communities to do this work is very important. But where we put the money also matters. I know in COVID, we've done a lot in trying to build ICUs and purchase ventilators and so on. But in Africa, a lot more money is needed at community level to just work with communities to build their capacity to know what to do. And that is what will stop COVID. And so as it is now, not so much money is going to communities, and that is where the solution really lies in our experience. Then the need to provide self-care tips is very important because of the failures that we are seeing in the health system. People need to be more empowered to control disease and to manage their health. And the things that they can do at home, they need to be able to do them. The other thing that works, which we have learned, is to institutionalize research as a way of contextualizing interventions. As I've said, being a new disease in a context of which is very different from other parts of the world, we need to slowly build evidence of what works for Africa and apply that evidence to the work we do. So in AMREF, we've done, we are doing a number of studies have been completed on COVID and community responses and health-seeking behavior and how COVID is interacting with other diseases. So we have studies on impact of COVID on adolescent health, on health-seeking behavior for maternal health, on HIV and FGM rates and so on, and also evaluating how the health workers are handling this pandemic, and also issues of health governance and how this is changing and affecting the running of health services. So basically, more research is needed, and this is what will help us to generate knowledge to be able to inform policies and the programs that we implement in Africa, because contextualizing is one very important thing in this pandemic. The other one is what we've learned is leveraging technology can help us scale up interventions very fast. In AMREF, we've used various platforms for various things, and there is one we call LEAP, which is a mobile-based platform for training community health workers. We deployed this to train community health workers in a number of countries, and we are able to train hundreds and thousands of community health workers in a very short time. I think part of it we are doing with Africa CDC. And so once they are trained, they are able to very quickly then take over the work that they have to do in communities. We have also used a platform called 𝐎𝐩𝐞 to train facility-based health workers, the nurses, the doctors on COVID. And we are now testing telemedicine initiatives just to make sure that we are also able to use this to scale up care. So what support is needed in the next phase as this pandemic goes on? I think vaccination is becoming very important. And one thing is that even when vaccines become available, they will not necessarily be accepted. Vaccine hesitancy is a big thing across the world and in Africa as well. And with social media, what's happening in the US and in other parts of the world are really being, Africa is being bombarded with these messages. And people are hesitating even before vaccines become accessible. And so in AMREF, we are seeing vaccine hesitancy studies as very important as an entry point into developing community mobilization messages for communities so that we improve acceptance of the COVID vaccine. The next one is, of course, training of community health workers on COVID vaccination. We know that in Africa, vaccines will not be given the same way as in the world. Community health workers will need to mobilize. We will need to have vaccination centers and they will be in charge of coordinating a lot of activities. But they need to be trained, they need to know about the vaccination, and we are developing a curriculum on that now. And then supporting the ministries of health is something we do all the time to effectively deliver the vaccine. We are developing trainings for health workers in health facilities, and we are also coming up with models of how to integrate services, vaccination services, so that the health facilities are able to provide these services without disrupting other health services. We also have agencies within AMREF which can help with procurement and so on, and we are able to support governments with that. And of course, supporting the delivery of the vaccine. We are also we continue to ensure continuity of other health services in Africa. We are saying that unless this is done well, there will be more deaths from other health problems than even from COVID. And so we must make sure that the disruption which we are already seeing does not lead to collapse in managing malaria, in managing HIV, TB, and other diseases which we commonly have here. And finally, research and advocacy to improve health governance, equitable access to vaccines is very important, and also to ensure transparency and accountability in the way we use resources and to allocate enough resources for this problem. Thank you very much.
Thank you, Professor Osun. Grazie per averci avvicinato.
Thank you for your overview and the African reality, the way in which different African countries are dealing with the pandemic, but also because you helped us remind that Africa is not only a series of problems, but also a series of solutions. It was very interesting to hear about this platform you're experimenting to allow distant training of health workers who has to deal with the pandemic, for instance. Next, we're going to hear Pietro Caburoso and Valeria Cathagno. We're going to talk about what InterSOS is doing in Iraq. I would like to remind all the speakers to stay in the minutes you're given. We started late because of technical issues, but we are late, so I don't want to be too much delayed. Thank you. You have the floor. Thank you and good morning. As we heard from our colleagues, InterSOS was able to give a COVID-19 emergency response, supported 10 structures, facilities in Iraq. We work for the protection, health, and education system with integrated approaches, trying to reach the majority of beneficiaries with a comprehensive program. We have reached more than 100,000 beneficiaries in the first year, thanks to 400 employees in Iraq and international operators. Can you see the presentation? COVID-19 crisis has had a huge impact on access to health, not just for the limited access, humanitarian access that we have in the country due to the lack of visa, but also due to lockdowns imposed by the authorities and the reduction of working hours in the public offices, which have driven to delays in implementing the activities. We had problems of lacking medical materials that were qualitative and also enough material. Many workers were put in quarantine and isolation. The interpreter can't hear the original audio, so the control room, I think, is solving the issue.
Sì, scusate, c'è un problema audio qua con Valeria. Vieni qua.
Scusate, queste sono le sfide che abbiamo ogni giorno nel field.
Sorry for the technical issues. It was a problem of my speakers. So as for health, we had a decreasing medical consultation, 15% less compared to 2019, and we had a decreasing in the distribution of health professionals because health workers were reassigned in hospitals that were set up to respond to COVID-19. Moreover, we had a decreasing in drug supply chain because the market was not stable at all. We had a disruption in supplying all the health services. As for beneficiaries, COVID-19 was perceived as a very serious pathology more than other illnesses. Patients were frightened. There was a lot of stigma also for the sick patients because they were coming back from hospitals or they have to be isolated. So they were isolated by their community and by their family. This had a huge impact on family relationships, but also psychological effects. There was also an interruption of care. If we think of chronic diseases patients, they didn't receive any treatment. Intersource has replied to this crisis in Iraq, revising the way they implemented the care at distance. We transferred the responsibilities to colleagues who were already present in the working areas. We made orders of medical supplies more often in order to have enough resources to allocate to the health facilities we were supporting. We updated all the procedures, not only for health, but also education and protection systems. All the awareness campaigns were made by phone or in WhatsApp groups or also on Facebook pages. Intersource has supported the Ministry of Health in Iraq through the implementation of a system to test all the ill people entering the medical facilities. Moreover, we try to supply personal protective equipment. We trained the staff, medical and non-medical staff, and we also made some awareness sessions in public for the community as for the protection from COVID-19 and how to prevent the contagion. The beneficiaries dealt with the situation, reducing, minimizing their consultation in medical facilities and in sending their family members to take the medicaments, but also by purchasing a big quantity of drugs in order to avoid and go often to the pharmacy, for example. As for pregnant women, they prefer to deliver at home. Can we go to the next slide, please? So what do we suggest to do? For sure, support the national authorities in order that they allocate more funds to the Department of Public Health in order to be always prepared. We should have more coordination among the humanitarian operators in the Nexus network. As for the operative part, we should plan and prepare the vaccination against COVID-19 for the most vulnerable people. Let's think of migrants, for instance. We should guarantee a continuous supply of medical equipment and also try to train on prevention of risks. If we consider the impact of COVID-19 on elderly people and also on people affected by chronic diseases, the priority is having a plan to be ready, an action plan to support this vulnerable category through some specific days, campaigns dedicated to these elderly people who can access to health services through at-home consultations and through a psychological support. Moreover, if we consider the decreasing of consultations we had in 2020 and the increasing of displaced people within the country, moreover in urban areas, we think it is obligatory to restrain our support to the facilities offering primary care in order to better access to health services for these vulnerable people and to avoid other epidemics linked to other diseases. Thank you for your attention. Thank you, Pietro, thank you, Valeria. I think you gave us a very rich and general overview of the things we should do and the difficulty in doing these actions because we have to act a long distance. So I wish you the best in Tersos and with your programs. Now I give the floor to Dr. Manal Tahtamooni, obstetrician with a long experience in the UN agencies like UNICEF and the World Health Organization. She will talk about IDOS action in the Middle East area. Please, Doctor, you have the floor.
Good evening, everybody, and thank you for this great opportunity to be with you in this webinar. Actually, I will present Jordan's case study and the impact of Corona and Corona response on the sexual and reproductive health and rights for women. So when we say leaving no one behind, actually, women are always left behind, and especially vulnerable women, especially in crisis. So as with I think the same happened in Jordan with the rest of the world in response to Corona and to COVID-19. However, I will maybe brief you on Jordan, a background on Jordan. So Jordan is a small country of lower middle income in the Middle East with a total population of around 10 million. 25% of them are other nationalities. 85% of the other nationalities are Syrian refugees. most of the Syrian refugees are living in urban setting and only 15% in camps. Till last week, the total number of COVID-19 cases were around 300,000 confirmed cases with around 4,000 related deaths. Jordan is in general having, let's say, positive and good health indicators, especially related to sexual and reproductive health compared to the region and the world. However, we have some issues related to the achievement of the global sustainable global indicators and sustainable goals related to health, gender equity, and other related indicators. So when I look into what happened during the lockdown, actually in Jordan, and starting from March 2020, the government started series of preventive and response measures as part of the global response and mobilization of resources to confront and control the pandemic. So most of the effect, and this continued for strictly for 3 months, and then with gradual opening of the sectors, closing airports and quarantining all those coming from outside the kingdom, closing educational institutions and most of official and private institutions, restriction of the movement of citizens, activating the defense laws, and deployment of the army at the entrance of the cities. This all been like total for 3 months and followed by partial curfew in all regions of the kingdom till even, let's say, very recently. We have this weekly lockdowns and limitation of movements at night time. And most of the institutions are now working remotely. And those who are working now are working with half of their capacities. The curve of COVID-19 in Jordan actually followed a very unique, let's say, curve. So we have very, very limited and small numbers of cases till August. And you can see in the curve, this is till the end of 2020, we have very, very few cases of COVID-19 till August. And then we have a rapid acceleration of the epidemic in Jordan. And we reported up to 8,000 cases a day with more than 25 positive testing percentage, more than 25 positive cases on lab investigation. So this all put a huge burden on the health system and the response of the health providers. If I want to talk about what happened, and in specific on SRH, sexual and reproductive health services, there were complete shutdown of all primary and secondary healthcare centers, public and private, for more than 50 days, and only minimum opening since that time till the end of last year. There were cessation of all preventive and early intervention services, including vaccination, limiting health services to only emergency cases in emergency rooms, and allocation of non-main hospitals to the treatment of COVID-19 cases. We opened field hospitals only last month, and with gradual back to a normal life in hospitals, and disruption of supplies for chronic disease medication and follow-up care, including family planning commodities as well, and closure of most NGOs, CBOs, with limitation of movement, not only for health providers, but for outreach workers, social workers, etc. So short-term impact of response on SRH in Jordan, the disruption of supplying family planning commodities leading to unplanned pregnancies, and disruption of antenatal and postnatal care would increase maternal and neonatal morbidity and mortalities. Women were afraid to go to hospitals, to emergency room, although that in Jordan we used to have more than 97% of deliveries in hospitals, the number of home deliveries increased, car deliveries increased because of the fear of going to the emergency room. The limitation of movement and psychosocial support, this increased the level of domestic violence and gender-based violence. And actually there were reports of increase of 33% of reported domestic violence and gender-based violence. And this was reported by the police department, family protection department, which is the official departments dealing with reported cases. So we use, like in Jordan, and as part of the globe, we say that this is the unhidden pandemic actually. Last year we lost 18 women, like homicidal cases, all from domestic violence. So, and this year, only in this month, we reported 5 cases of homicides, all related to domestic violence. So I think this is as well is a great and huge problem now that is affecting the health of women in parallel to the disruption of SRH services in general. Now, the limitation of movement as well as increased unemployment for women lead to decreased access to services. Although women in Jordan have very, very low participation in economic and social life, they contribute only to 14% of the workforce. And now we're reporting around 50% drop out of the workforce, and women are kept at home. Even those women who are working from home are facing issues in marketing their products, in accessing services. So this all attributed to gender-based violence, domestic violence, as well as to the short-term impact on SRH. The part of the challenges and lesson learned from the response is that there was no woman actually in the emergency management team to respond and to reflect the needs of specific needs of women in emergency situation and response. SRH was completely not considered a priority issue during the pandemic response, and SRH is not a component of the Ministry of Health Emergency Response Plan, and definitely not the National Health Emergency Plan. There were poor coordination among different health stakeholders, especially the public and private health sectors, and with other sectors like with education, with security, that will ensure the mobility of health providers and others. There was poor, if any, participation of the civil society organization in the response management. They were not part of the coordination and part of the response mechanism, as well as with the limitation of movement and the shifting of the funding and closure of many clinics and many projects toward COVID-19 response. Most of the projects implemented by civil organizations were closed. So many organizations and many health providers have, let's say, implemented some mitigation approaches, like, for example, the provision of remote essential package services through like remote counseling services for family planning, antenatal care, and postnatal care. However, this was of very limited scale and mainly in main cities, but not reaching out to the remote areas and camps. The second approach is the distribution of chronic disease medication and family planning in some areas by community-based organization and voluntary groups. And this was like an approach like on and off based on the defensive laws, limitation of movements, etc. And finally, the establishment of hotlines, including those for GBV, clinical management of rape, and other services. And currently, I'm leading a hotline initiative at a national level that will be, we hope that it will be sustainable, and we'll continue to do that even after inshallah, the complete response to COVID-19. So according to all these challenges and all these mitigation approaches, our recommendation is the need to adapt the MESP, which is a minimum initial package of reproductive health in emergency in all emergency response, although that was recognized in the emergency response plans for the government, but there were no, let's say, attempts to actual strengthening of the implementation of the MESP, as well the inclusion of SRH in emergency objectives and activities and in all national plans and strategies. And actually we are now revising all the national plans and strategies to ensure that we have emergency component, including SRH in emergency. Then the development of preparedness and response plans with clear SOPs to emergencies, including pandemics. And so it will not be like ad hoc response, but would be with proper preparedness, including capacity building, preparation of stocks, etc., and ensuring the training of health providers on dealing with emergency. The support needed from international partners and donors to Jordan NGOs and even the government is we need more studies and researches and assessment of the actual impact of COVID-19 pandemic and response on SRH services, including GBV, and to provide technical support to Ministry of Health and other stakeholders on inclusion of SRH in emergency within national plans and strategies, and actually the actual implementation of such inclusive strategies in reality and enduring response to crisis, and the technical support to the civil society organization and strengthening their role in emergency response. And thank you.
Molte grazie, dottoressa Tartamuni.
Thank you, Professor Tartamuni. You have drawn our attention on the situation on the Jordan context and the situation of women as victims of the pandemic and of the consequences of the pandemic. It is a focus that is very important. Thank you for your intervention. And the last representative of the NGOs is Andrea Azzori, representing QAM, Doctors with Africa. He is dealing with the international relations with donors, with big UN agencies, where QAM projects are present and where we have some privileged relationship with this organization. So I will give you the floor.
Thank you. I will do my presentation in
Thank you.
It is my duty to present the intervention of Doctors with Africa QAM for COVID-19 in Africa globally and in Italy. You may know Doctors with Africa QAM. We work in 8 countries. We try to strengthen local health system to provide basic healthcare services to the people, especially in the last mile and for the most vulnerable, like women and children. Of course, COVID-19 represented a big shock to the local health system and posed a number of challenges. Next, please. The first intervention we did was in Africa. Our background working epidemics and working with health system, for example, Ebola, cholera epidemics, we started immediately trying to secure health facility. So we set up triage system, we provide PPE, we set up WASH for improving hygiene and infection control at hospital level. This was in 25 hospitals around 8 countries and in hundreds of health centers that adhere to these hospitals. The second big area of work was training healthcare provider in the correct use of protection items, PPE. These PPE need to be dressed and undressed properly, is a major factor in preventing and protecting operators, and the training package was delivered in the first week of the first wave of COVID. And third, as we heard from colleagues from other NGOs, was to put an attention and focus on community intervention. We used our network of activists that usually work on HIV, tuberculosis, maternal health. We use them to try to avoid stigma, to educate people about distancing, social distancing, use of masks, and wash practice. We been going around identifying suspect cases and refer them quickly and safely to the hospital we've been securing. These three were the kind of main area of work in Africa. Next. Of course, how can we sustain such a massive intervention? 25 hospitals, hundreds of health centers, thousands of operators, and a lot of PPE in a time where the PPE price was skyrocketing. It was very difficult to procure. So, like the deputy director of CDC said, we need a good partnership. We need global partnership for a coordinated response. Nobody can respond to a pandemic like COVID alone. We need to work together and have a common goal. And this will be good for the vaccine as well. But we did it for example, the PPE. We signed a partnership with the UNHRD, that are humanitarian hubs. They are all over the world. We use mainly Guangzhou in China and Dubai. And we start to procure globally PPE, and thanks to the help of World Food Program, ship them with humanitarian flights to the country and the ministry. And the ministry then was in charge to distribute it to the facilities. If you see them up on my left, this is just a sample of the flights we've been organizing and the tons of materials that we've been shipping over. Next, please. And the experience we've been collecting in Africa over the years and during the first response and the international partnership we've been building raised the attention of the capacity of 𝐾UAN to provide some help at home in Italy. So during the first wave, we also discussed with the USAID, the International Agency for Development, for an intervention in Italy that has four main pillars of work. The first one was, again, hospitals and health operator. How can we help them to set up triage? I have a limited experience, but all the experience I have in emergency and epidemics, I know that triage is a triage. It doesn't matter if it's in Italy or if it's in Africa, but the experience you have in screening people, organizing the patient flow, and reducing infection at hospital level or at the access of the hospital are basically the same. So this is a science that is really global science. And the second point was to put at the center of everything the health operator again. So with training packages that we are going to launch in these months all over Italy. The second point was to work on vulnerable people in Italy. The third was to digitalize the communication we have with our territories and the community in Italy. And the third was to strengthen and update the discussion, international discussion with the network of university we have in Italy about the global health issue. So these were the three main areas of our intervention. So again, was the African level with the facilities, was the international partnership, raising funding. That was an important part of the work, but especially finding new partnerships that are able to deliver to the last mile. So partnerships that may have very important hub logistics, that can provide PPE, they can ship them to the country, but then they need an NGO like 𝐾UAN or the other NGO we've been listening today to deliver to the last mile, because that's a big challenge. And then was interesting to use all the experience collected in this year also to give a small contribution, but we hope important contribution to Italy as well. Next. So, but what is the scenario now? Because we have the first wave, the second wave, the South African variant, the UK variant. So it's a quite complex scenario. Are we worried just about the COVID infection? Actually, no, especially in Africa. What we are seeing here, there are three main concerns in 𝐾UAN at the moment. The first one is, and we heard from other organizations as well, the problem of the reduced access to health programs and health facilities. For a number of reasons, that goes from the lockdown, for example, we did in certain African countries, to the current situation of the stigma. People are not accessing services deliberately sometimes, because women don't go for visit. Antenatal visits are very important. They don't go because they are afraid to get infected, or for other reasons. Maybe there is a a police control along the road, they're afraid to pass by, so they don't go to the hospital. That is really worrying. The second main area for the way forward in Quang will be to discuss what kind of mitigation strategy we can put in place. For example, one thing that we are seeing, especially on pregnant women, is how important it is to provide food at this stage. Much of the informal economy in Africa, I hope the colleague from CDC and their analysis are agreeing with me, are collapsed because some lockdown procedure and some lockdown because of fear and stigma. So this informal economy, especially for women, was very important in providing food, in providing some cash, some items for the families. They don't have that. So inside the programs we do now, for example, we incentivize women to come to hospital. Of course, we inform them, we educate a community that is safe, but we inform them as well they can receive some basic, for example, food incentive. And the third one, if you can go back to my slide, please, for a second. The way forward, please. Okay, is the importance of sharing and learning best practices. So there's been a lot of good practices in Africa. There's been a very quick response. There's been a lot of mitigation strategy, adaptation. There's been a lot of fight on stigma, education. All of this is, my opinion, done country by country, almost hospital by hospital. There is a great deal of learning and sharing we can do now. There is a great opportunity to strengthen health system. There is a great opportunity to find new way in which we can fight stigma for many diseases, not just the COVID-19. Because what we are seeing is that from bottom up, we can gather a lot of data, but also information and practices, and also putting at the center health operator, we can really develop new training packages completely out of the box, but probably more prompt, more resilient community and health facilities and health programs can come out from learning and sharing experience. I want to finish here in saying that all of this, of course, is the base in which we can plan for a good vaccination campaign in Africa. We need a vaccine that is that everybody can access. We need some mitigation or incentive strategy for people to get the vaccine. And of course, we need to share our experience, our thoughts, and our best strategy in order to reach the last mile. If we reach the last mile, if we reach the most vulnerable in Africa, it works. So it can work everywhere. Thank you very much.
Ringrazio Andrea Azzori.
Thank you, Andrea Azzori, in particular for the focus you had on the relation with partners, because in this last part of our meeting, we're going to talk about very important partners that we are going to hear. These are institutional partners, and debating with NGOs representing the government, the Italian government, the Ministry of Foreign Affairs, the Agency for the Cooperation and Development, and the Ministry of Health. I will introduce them very briefly. Giorgio Marapodi, Director General of the Directorate General for Development Cooperation in the Ministry of Foreign Affairs. After him, we're going to listen to Luca Maestripieri, Director of 𝐼𝐸𝐞𝐧𝐢, the Italian Agency for Development Cooperation, and last but not the least, Sandra Zampa, Under Secretary of State for Health. I apologize because we are late. I can now give them the floor. We started a bit late because we had some technical issues, so I really apologize for this, but thank you for your presence here, and I now give the floor to Giorgio Marapodi. Please. Thank you. It was very interesting to hear all the interventions that we had this morning. Presentation of Roberto Ridolfi, the link action, and hearing the voices of all the participants who presented the work done so far. I will focus on bilateral relationship. At the beginning of 2021, we have already seen the progress we had done, particularly in contributing to build a multilateral architecture in response to the pandemic. When the crisis came to Europe, Italy was the first country impacted. The first country touched by the pandemic, but also among the most active countries to promote multilateral mechanisms for a global cooperation. I would like to remind the first case. We were the first to talk about the need for an international debate in G7 to have a unite response. This proposal then was put forward G20 created Mr. Marapodi has internet problems, so it is not possible to follow his conversation.
Mettere le basi per implementare il per sviluppo, la produzione e la distribuzione di strumenti terapeutici, medicinali e vaccini in linea con l'obiettivo di equo accesso, economicità e sicurezza. L'Italia è stata lavorazione, che è il cosiddetto acceleratore per i trattamenti strutturati in tre leggi in conference dedicate alla credo sia importante ricordare che il G20 era intervenuto anche che spazio per manovre di natura, quindi l'Italia insieme a
Marapodi, abbiamo un problema di qualità della linea, il collegamento attraverso il cellulare.
Yes. We have a problem with your connection, so we can't hear what you say. I'm very sorry. I don't know if you can change your connection or to maybe using another device, because the smartphone is not a very strong internet device. I don't know if you can continue your speech, because we really can't hear you. I'm sorry. I don't know if you can hear me or not. Let's try and see if we have a better connection with Luca Maestripieri. Maybe you can take the floor while we wait for a better connection by Giorgio Marapodi. Thank you. You have the floor. Thank you, and thank you to Link Network for this occasion of meeting, and thanks to everyone who gave their own experience from the field that are very useful to reinforce our action on this issue. That is a very challenging issue. I started my speech trying to summarize the Italian cooperation guidelines, because if we consider the global health sector was always been in the DNA of Italian cooperation. Even before the pandemic, the principle on health in 2014, Italy followed the best strategy at an international level and had great results in supporting our partner countries in the health sector. Private and public Italian actors has always offered such support, and the testimonies we had are the proof of that support. The main objective of Italian cooperation has always been towards supporting partner countries in realizing the health coverage, particularly referring to measures aiming at guaranteeing health for all people, namely most vulnerable people, women, children, handicapped people, but also refugees or migrants, so very weak categories, contributing to prevention and this chronic disease control and countering the main risk factors, fighting the main infectious diseases starting from HIV, promoting and protecting maternal children health, also sexual and reproductive health, treating malnutrition. For each of these type of intervention, I could name some examples, but as I don't have enough time, I won't go in detail in so many actions we put forward in the last years. Despite this huge recognition of activities, it is known that 1 year ago, when this pandemic started, we were forced to revise our activity on different levels. At the same time, this pandemic confirmed the need to engage in the health sector, not only to fight against COVID-19, but also to stress the collective engagement for sustainable development objectives that this pandemic stopped. How did we try to counter this crisis? I won't talk about the different multilateral tools, because this is the intervention of Mr. Marapoti, so I hope he can go back and tell you more about this topic. But I just would like to make some examples of the Italian government action through the agency, the 𝐼𝐸𝐾𝐽, that is the executive body for cooperation development laws. As for bilateral cooperation that we have through interventions implemented by our offices abroad or that are transferred to our partners, included the NGOs, of course, all around the world. As the pandemic started, so since last spring, we had many disruptions. Also, our institution, in a moment when mobility was put to zero, our agency, since the beginning, while waiting to update those guidelines of 2014, implemented some actions in our abroad offices to encourage actions, identifying and reprogramming actions to face COVID-19 emergency, some intervention in health sector or disability sector, child protection, education sectors, and so on, which were the main achievements that should have the right response in the intervention that will be adopted from now on, reinforcing health services, health facilities in dealing with emergencies. reinforcing health facilities at the local, regional, national level for our partners, the adoption of prevention measure and early prevention and treatment, supplying of equipment and drugs, medicaments, and also protection devices, reinforcing capacities in laboratories, a good waste management, and also reinforcing the link with central structures, supplying home care to identify patients who can have symptoms of COVID-19. We have to have a risk plan with all civil society actors, education institutions, workplaces, and identifying the most vulnerable parts of the society for the high risk of contagion, and try to draw their attention to the access of treatment, guaranteeing social protection. We also have to ensure free of charge testing for all the population, protect population from contagion, try to sanitizing all the facilities, ensuring waste management, and the supplying of hand sanitizers and protective equipment. We can talk about all the interventions, but it is important to think of all these guidelines made by 𝐼𝐸𝐾 to give the maximum contribution to all the actions it is possible to think at a local level. What are some examples of actions, ongoing actions concerning the pandemic? I have listed some of these actions: raising awareness for handicapped people in the framework of Bridging the Gap in countries such as Sudan, Ethiopia, Paraguay, the campaign for raising awareness in health facilities of gloves, glasses, masks in different countries, Kenya, Mozambique, and others, training for COVID-19 for health workers coordinated by Italian universities in Somalia, raising awareness for young mothers and pregnant women on hygiene norms to follow, and the material in local languages in countries such as Burkina Faso and Niger. Other actions that 𝐼𝐸𝐾 implemented to counter the epidemic concerned the measures implemented for the civil society organizations. I will conclude. I remind that on the 31st December 2020, we had the official journal with a public comparison procedure for synergies promoted by research bodies, university, for €2,650,000,000. The contribution will be allocated to measures to counter the negative effects of pandemic. The due term is the 19th of February, so the deadline to present the candidacy. COVID-19 pandemic has determined a disruption in all activities who were ongoing last year for different intervention corporations. So the agency had an emergency fund of €13 million who allowed during the year and continues to allow to finance the organization of civil societies who were on the field and were acting in order to finalize the objectives of all the projects that were ongoing. I thank you for your attention, and I'm available for any questions you would like to ask. Thank you. Thank you, Luca Maestri Pieri. Time is running up. Of course, we have a lot of activities we can see the agency is engaged in. It is very important work, so We have some questions, but I doubt we will have time to listen to these questions and to answer to them. And now I have to give the floor to our Undersecretary of State for Health, Sandra Zampa. I thank you. Good morning. I thank you. You all. I apologize because I have other meetings after this one, so we'll try to be short but efficient. So thank you for your invitation to represent our experience on health international cooperation during COVID-19 pandemic. First of all, I would like to say that our Italian presidency for G20 chose this topic as one of its priorities. My offices are working on the event that will accompany the G20 events concerning mental health. One of the fragilities that was the most affected by this pandemic, of course, mental health. You will recall that in Italy we talked a lot about it. Italy was the first country after China having to deal with the impact of the COVID-19 pandemic. And this, of course, challenged our health system, our lives, the lives of our citizens, and we learned from these experiences. It was very painful, but we learned a lot. Now we have to make sure that what we learned will become part not only of our memory, that for sure we have to accompany us, but also be part of the ability of implementing effective measures in the future. The first of these measures, of course, is the revision and the approval of a new plan to counter the pandemic, an updated plan considering what we have lived. What we should remind is that we have to invest in finding and testing at a national and international level. COVID has proved what is globalization. Nothing else could have explained it better. We couldn't imagine that when we talked about the globalization and the ability to move from one part to the other of the world, but we couldn't imagine something so serious. We could have never imagined that from a very small part of China, we would have received a virus at home, something that became very huge. So the virus epidemic. I was talking about rapid tests at a national and international level, managing the risk, the communication of risks. These are the elements that we're going to stress as a lesson to learn in the future. As for the most vulnerable categories, within the actions we have implemented, and I would like to recall, because we are proud of that in Italy, is that last month with the International Institute of Migration of Poverty, a ministry that is monitored by the Ministry of Health, we gave the guidelines to manage facilities with very vulnerable people in the framework of the COVID-19 pandemic. We are referring to guidelines, shared guidelines in the tertiary sector that are more engaged in managing the welcoming facilities for migrants, foreign citizens, with no fixed home. We're going to understand how to implement this plan of vaccination. I will going to explain better. So this aims to find some guidelines for protecting vulnerable people, trying to contribute to standardize behaviors while managing the epidemic in very difficult settings where very fragile and vulnerable people are present. All the welcoming centers are concerned. We are considering how to protect people. I would like to say the common engagement between institutions and the tertiary sector. It is a very small example of cooperation. The solution we have found recently, because unaccompanied foreign minors don't have to stay on boats to do their quarantine, but they should be placed in facilities dedicated to them. So in the G20, we decided to deal with cooperation, international and national cooperation, so to have clear ideas about what cooperation today means, what health means in a globalized world. These are three main points we were able to be present. Planning a shared response on a national and international level to crises and to health emergencies is one of the sectors we should work together with the UN agencies, with international agencies, and all the actors implicated in order to reach a great mobilization of multidisciplinary teams, considering particularly vulnerability in less resilient countries and of less resilient categories. A mechanism of cooperation has been implemented in the past in a very effective way to counter a health emergency, referring to the Ebola emergency in 2013, 2016, Sierra Leone, Guinea, when we had funds to train health and medical professionals to support coordination and logistics. Through bilateral initiatives promoted by other NGOs in the affected countries, we could finance treatment, training, and support to health facilities. Recently, Italian contributions have been approved to reinforce health and system and health regulations. This is something we can compare with COVID-19 pandemic. This has been said in different cases, and in the case studies that showed differences in the spreading of the disease. We see that today we have more than 100 million contagious people in the world, affected people in the world. It is important to work together, but with a wider point of view to counter this epidemic and ensuring an international governance and information flows that are efficient, considering most vulnerable people, ensuring a supply chain for medical equipment and medicaments. One of the main objectives is the innovative use of data in the health sector. This is something I would really like to draw your attention on. Italy is supporting policies for digitalization and planning of big data. This is something that will prove to be a very strong tool for policymakers. It is important to invest more on digitalizing health services, but also to assist and accompany this revolution in the countries needing a support from more developed countries and wealthier countries. This is an extraordinary investment in a tool that can go faster, more than any other tool, and can work on a global level. It is necessary to have an international cooperation, transsectoral cooperation, to supply medical equipment, such as new intelligence platforms on health, public health, foresee epidemics, monitoring, early diagnosis, and having trained staff to counter emergencies in health sectors. We should increase the resilience of the health sector so as nobody is left behind. The title, No One Left Behind, is not a philosophy, but this should be a mantra, a refrain accompanying us every day, a motto, a strong motto, to implement a response, integrating the human health in sustainable development. Never before, we don't have to leave anyone behind. It is important not only on a humanitarian level, but also of public health terms. If someone will be left behind, if people will be left behind or not reached in the same equal level by vaccination, they wouldn't have the same access to vaccination, we will have a development of varieties of the virus, and this will represent a continuous challenge for those hoping to be safe because they had the vaccine. So each country should have access to vaccination, particularly in this path. We should not forget fragilities who remain an element of public health. So that has to be reached in an efficient way and to be protected. So we can implement those strategies to support development and supply of treatments and vaccines. We're living the most important vaccination campaign at a national level, and we have a strong mechanism of cooperation that has to be reinforced, and we all have to engage that this is the direction we are following all together. Partnerships between countries, private and public sectors, industry, the approach of the 2030 Agenda with its 17th objective. The International Alliance for the Research of a Vaccine Against COVID, launched by the Ministry of Foreign Affairs last March, that was implemented by this ministry, particularly by Minister Speranza, encompassing the dimension of the challenge we have to face, is implemented through tools such as COVAX facility, to which many countries adhered. This should facilitate the distribution of vaccines in many partner countries. In the last weeks, the participation to COVAX 2 was made stronger, with more than 170 countries involved. Italy is participating to the financing of the Coalition for Epidemic Preparedness and Innovation. That is a fundamental component of this alliance and is leading an international alliance based on vaccine diagnosis and therapy. It was launched in April by Director General of the World Health Organization and the European Commissioner. So once again, I would like to stress that COVID-19 era highlighted the difficulties of many sectors, but also highlighted the fragilities in the world and of humanity. But as all crises, it offered an opportunity, an extraordinary opportunity, to recognize, to acknowledge that cooperation at an international level can be a tool to reach great advantages for human beings, giving a concrete implementation to the concept that we have to leave no one behind. Thank you, Ms. Zampa, particularly because you recalled in the last part of your intervention our motto of this meeting, no one left behind. We have questions about this issue because, as we know, COVID emergency has displaced resources to face this last danger to global public health. We know that resources are stretched, so it had a negative intervention on resources that were not enough in the past. So we got distracted by the continuous treatment or the supply of saving lives drugs for chronically ill people. So the risk that someone is left behind has increased. And I think that as you all have to think of global strategies, this is a huge problem that is part of your daily life and fear, also for people who are not concerned in the works like me. We have many questions from the public on this specific issue about the strategy of allocating resources facing this new problem that is distracting from chronic disorders that are not less risky for human health. We still have some minutes if anyone would like to add something more, because this is a very specific issue. I have 30 minutes. I am 30 minutes late, but I will be glad to receive written questions at the ministry, and I will give my answer and reflections about this very important topic. It is something that is very, very important. We have paid a price in terms of health, also in our country and in other European countries, because, of course, in this moment, the system was disrupted in giving a response to COVID-19. For this reason, many other health needs were left behind. So I apologize with you, but I am late. I'm 40 minutes late for other meetings, so I have to leave. I'm so sorry, but I will answer to your questions. Thank you, Secretary. Now I would like to invite Nino Sergi. Know if Luca Maestri Pieri would like to talk, because I see he is connected. Resources issue is very complex and as well as important. We continue our action on the base of resources that are allocated by the financial statement of the Ministry of Foreign Affairs. I'm glad to stress that the plan of this year is no different from the previous years. This is a great success. So as for resources, we are an agency trying to operate at best and try to make our intervention efficient. The quality of resources we have, of course, go beyond our competence. Thank you, Mr. Mastripieri. Nino Sergi is the founder of Link 2007, as we said, is the organizer of this meeting, but also was founder of InterSource, president of InterSource for many years. So let's try to have some conclusions together. You have the floor. First of all, thank you, because this webinar was, at least for me, very interesting, and I had new horizons compared to my views. So thank you, AHMED. Thank you to the voices from the field, Joachim, Pietro, Valeria, Manal, Andrea. And then also thanks to the institutional representatives that we feel very close to us, particularly the three people who have spoken today: Director General Marapodi, Director of 𝐼𝐸 Maestri Pieri, and then the Secretary, Ms. Zampa. These are people we feel very close to us because from the point of view of values and actions, we have a united point of view. So no one left behind. It is a strong affirmation that we should cherish and we should repeat and maintaining as a fundamental objective, even if we know it won't be true, because we know that someone will be always left behind. Because problems are very difficult to solve. Today's webinar forces us to have a wide opinion in the space, but also wide in different sectors. So multi-sectoral and multi-actors, international and national actors. Problems sometimes don't deal with the current distribution of the vaccine for the current pandemic. That is a real problem, of course. As the World Health Organization, in Africa, we had few doses of vaccine distributed. So we're really backward. But the problem is not only the distribution of a vaccine, but as we have seen in these 2 hours, problems are globally in the health sector that cannot provide good responses. The coordination is fundamental because nobody can act alone. So we should act at an international level. Communities have to be informed in a transparent way. They have to be trained with operators and to respond to their basic needs. Someone don't want to hear about COVID because they have the problem to eat every day and to find food, or their children are not going to school. They are unemployed. That low income they have to survive. All these problems have to be reminded and tackled as we feel the need to have the vaccine. Also, we talked about the protection, another important point, against gender-based violence that are particularly increasing in this period. Safety, and also the lack, as we always say, even the lack of adequate financing, lack of medical personnel, lack of supplying of medical equipment, and the severe consequences in all affected countries affected by COVID-19. If we think of vulnerable countries, let's imagine what consequences they can have. So here I refer to what Roberto Ridolfi said at the beginning, this proposal and the reconversion of the debt. So as we use this amount of money, not to give it back to the countries, the project countries, but to allocate them in development projects, particularly in the health sector in the same countries. We have to acknowledge that our government's action, so the Italian cooperation, the current and the forecasted planning for the next 3-4 years at a national but also bilateral level is going in the right direction. What is written confirmed the proposals that were made and the needs that were identified. These are aspects highlighted by Director Maestri Pieri, but also Mr. Marapodi, and also by Undersecretary Zampa. What can we understand from all that? The implicated actors to counter these big difficulties, the role of organizations of civil societies, of NGOs, is fundamental. A message I would like to leave you at the end of this webinar is that Italian cooperation has to enhance more than it is actually currently doing, because these organizations can have that narrow contact and experience through time in those communities that are the actors we should pay more attention, because these are the subject from which we should have the solutions in their countries. So thank you all again. Thanks to everyone. I didn't talk about the organizers of this webinar and these works. Pietro Veronese, you were a great moderator in this webinar. You have summarized the essential points that were said by every speaker, so I don't have to add anything else. I'm convinced it was a very fruitful webinar, and we were able to open our eyes more than we did before. Thank you all. Thank you, Mr. Sergi. So goodbye, everyone, and thank you for having been with us.